So my name is Katrina Baxter. Thank you for that introduction. I work at Fredericton Medical College. I have been a nurse practitioner for just over 11 years now, and nearly 10 of those I have worked specifically with this heart failure population. I'm certain that many of us listening tonight come from a variety of background when it comes to awareness or management of the Barostim device. So briefly, an overview of what our center looks like. We're located in Wauwatosa, right outside Milwaukee, Wisconsin, and we do have a comprehensive advanced heart failure program. We run a 711-bed hospital, and we do see just over 5,000 heart failure patients in our clinic. I broke that down further, and just over 2,000 of those are heart failure with reduced ejection fraction, with the greater portion of our patients being heart failure with preserved. Actually, we just did one additional transplant since I made this slide, so we're at 21 transplants for 2023. We're following 31 LVADs currently, only 3 of which are bridge to transplant, and we're following 180 post-transplant patients. We began implanting Barostim in late 2022, and we're currently managing 8 patients post-transplant. There is that we do have a large number of patients in the queue when we resolve one more internal issue, and then we look forward to expanding that population of patients. So first, I'm just going to introduce a typical patient in our clinic that we could consider for this therapy. We have a 77-year-old female. Past medical history is significant for chronic ACC-AHA stage C heart failure with reduced ejection fraction, and this patient had ischemic cardiomyopathy. Past medical history is significant for ischemic cardiomyopathy, previous myocardial infarction, PAD, ventricular tachycardia. This patient has an ICD implanted, hypertension, and diagnosis of obesity. Surgical history is significant for cholecystectomy, right femoral and external iliac artery intervention, coronary bypass in 1988, appendectomy, tubal ligation, and a diaphragm plication. This patient had a left and right heart catheterization completed in April of 2022, revealing widely patent stents, and was unchanged from her 2020 cath. She had low normal filling pressures and normal cardiac output and index. Around that same time, she had an echocardiogram, which revealed her left ventricular ejection fraction to be 20 to 24%. She did have known regional wall motion abnormalities and moderate diastolic dysfunction. This patient was on maximally tolerated guideline-directed therapy, which included the following medications. She was on spironolactone, empagliflozin, toprol, Entresto, and vericiguat. She was presenting with functional class 3 symptoms. She was able to perform basic ADLs with minimal symptoms, but experiencing significant limitations with any type of exertional activities. She was able to walk 1/2 a block, and then she would feel short of breath and fatigued, would have difficulty climbing 1 flight of stairs, and was not experiencing orthopnea or PMD. She was not a candidate for CRT therapy, and her NT-proBNP trends were stable in the 415 to 908 range. So as we look at a patient like that, this was a patient on maximally tolerated guideline therapy, but still struggling with minimal daily activities and not a candidate for CRT. So what's next? Many of our heart failure patients do fall into this symptomatic category, and of course, we're always risk stratifying them for other options. Heart failure is a serious chronic condition that will get worse over time, and it can severely limit the activities that you'd be able to do and is often eventually fatal. Heart failure is a leading cause of hospitalization, and it is associated with high risk of both short-term and long-term mortality. While hospitalization is not specific inclusion criteria for Barostim, it may be a good time to evaluate if your patient is a candidate for this therapy in order to change the trajectory of their clinical course, and I'll talk more about why that might be true. With significant advancements in drug therapy for reduced ejection fraction patients, we can ask ourselves, do we even need a new device for patients with functional class 2 and 3 symptoms? Our 2022 AHA, ACC, HFSA guidelines now include 4 medication classes when we're treating our heart failure with reduced ejection fraction patients, the latest addition of being the SGLT2 inhibitors. And when used in combination, there's a significant morbidity and mortality benefit. Despite the published morbidity and mortality benefit, many patients are unable to maintain target dose or all 4 guideline-directed therapies. Sometimes this is related to cost, intolerance to a medication, maybe adverse effects or an allergy, or just simply unable to reach the target dose. The dark green section on this slide shows the number of patients who've been able to reach the target dose of therapy, while the light green represents those at an intermediate dose, which leaves a large portion of heart failure population that remains under target dose or have in fact discontinued the guideline-directed therapy at 1 year. Functional class 2 to 3 patients have very debilitating symptoms that are impacting their quality of life. So what can we offer them if they are truly maxed out on tolerable pharmacotherapy? And of course, this is in addition to volume optimizing these patients. In 2 different studies, one led by Jane McLevere and another led by E.J. Stanek, they summarized that patients with symptomatic heart failure had a preference for outcomes that resulted in symptomatic improvement versus survival improvement alone. And overall, the majority of patients did prioritize treatment options that contributed to their quality of life. GDMT produces modest at best improvement when it comes to exercise capacity. So again, we're very aware of the morbidity mortality benefits of these therapies, but when it comes to exercise capacity and quality of life improvement, it has not proven to be clinically meaningful. The Metric heart failure study evaluated potential impact of increased myocardial contractility on multiple important measures of functional capacity on our ambulatory patients with symptomatic heart failure with reduced ejection fraction. Decreased baroreceptor signaling in what results in dysregulation of the autonomic system. The graph here shows in the upper right the specific impact of drug therapy on functional and exercise capacity. Beta blocker is the least of these, as it is a beta agonist, and we understand that optimizing heart rate and rhythm has been shown to be most beneficial with regard to exercise capacity in the CRT category. CRT is a great option. However, it is only available to about 30% of the patients that then fall into that category. Specifically, we can review what the indications are. So there is a class 1 indication for CRT for patients who have reduced ejection fraction under 35%, are in sinus rhythm with a left bundle branch block, and have a QRS duration of greater than 150 milliseconds, and have functional class 2, 3, or ambulatory 4 symptoms on guideline-directed therapy. Or for those patients with similar qualifications without bundle branch block, they may still qualify as a class 2A recommendation. This, however, leaves 70% of the patients that fall in this category that are not eligible for CRT and are still experiencing those functional limitations despite their optimal medical therapy. So heart failure should be thought of as a systemic disease process that manifests as an extreme case of autonomic dysfunction. Once our bodies recognize that initial event to our hearts, whether it be an ischemic event or non-ischemic, it moves beyond the heart and we develop chronic activation of neurohormonal compensatory responses. When activated in the short term, these responses are intended to maintain cardiovascular homeostasis. However, over time, this leads to ventricular remodeling, progressive systolic and diastolic dysfunction, as well as abnormally reduced fluctuation in heart rate over time and increased norepinephrine activity. The autonomic dysfunction leads to worse prognosis and has been an important therapeutic target. So baroreceptors sense changes in our blood pressure, and they send signals to our brain that control heart rate and vascular tone. However, when there's decreased signaling and sympathetic nervous system is activated to provide inotropic support to our failing heart by increasing stroke volume and peripheral vasoconstriction, eventually this accelerates the heart failure disease process. Increased sympathetic activity in heart failure is related to higher frequency of arrhythmia and increases mortality. Parasympathetic tone is decreased, thus reducing heart rate variability and decreasing exercise tolerance. So both of which increase heart failure symptoms. Afferent signaling to the brain via carotid sinus nerve acts to rebalance the autonomic input to the heart, and atrial baroreceptor reflexes normally contribute to cardiovascular homeostasis. This preserves blood pressure during changes in volume and posture. However, an underactive or dysregulated nervous system can present different symptoms which impact quality of life, including low energy levels, feeling sluggish, or feeling short of breath. In moderate to severe congestive heart failure, a depressed sensitivity of vagal reflexes parallels the deterioration of clinical and hemodynamic status and is significantly associated with poor survival. If we were able to impact the baroreceptor modulation of heart rate, could we rebalance the autonomic nervous system and therefore improve heart failure symptoms? I'm going to show you on the next slide a short video which will explain the mechanism of action of the Barostim device.
Barostim is an option for heart failure patients that electrically stimulates carotid baroreceptors to improve the symptoms of heart failure. The baroreceptors play a critical role in maintaining cardiovascular homeostasis by simultaneously regulating the sympathetic and parasympathetic branches of the autonomic nervous system. Afferent signals from carotid baroreceptors are constantly transmitted to the brain to interpret. The brain uses these signals to regulate heart, kidney, and vascular function via the autonomic nervous system. Patients with heart failure have decreased signaling from baroreceptors, which results in an increase in sympathetic and a decrease in parasympathetic tone. This imbalance in the autonomic nervous system leads to worsening heart failure symptoms. Barostim is delivered through a small pulse generator and an extravascular carotid sinus lead. The system works through continuous electrical stimulation of carotid baroreceptors, increasing signaling to the brain, resulting in a decrease in sympathetic and an increase in parasympathetic tone. By restoring balance in the autonomic nervous system, Barostim has been shown to significantly improve patients' exercise capacity and quality of life.
So the BEAT-HF trial was a prospective multi-center randomized trial, and the study was deliberately designed to have two phases. The first of which was a 6-month symptomatic outcome, and then the post-market phase for morbidity and mortality. Patients were randomized 1-to-1 to receive either baroreflex activation therapy plus optimal medical management or optimal medical management alone, which was the control group. And patients were followed for 6 months for the 3 primary efficacy endpoints, which evaluated 6-minute walk results, quality of life, NT-proBNP, as well as a safety endpoint. And the results of the primary efficacy endpoints around symptomatic improvement led to the FDA approval in August of 2019. It was important enough to the FDA to make this device available based on symptom relief and approve the device before the morbidity and mortality data came in. And of course, optimal medical management was defined as maximally tolerated guideline-directed therapy. Sorry. So 65% of patients treated with Barostim and guideline-directed therapy had improved NYHA class by 6 months. So 52% of these patients improved one class and 13% improved two NYHA classes. And this was a 34% difference compared to patients with optimal drug therapy alone. And for context, though we cannot compare the studies as they're different patient populations, the CRT trials noted a 20 to 30% improvement of NYHA scores at 6 months. So it can be considered comparable with regard to NYHA improvement. And the BAT did not produce hypotension in normal-tensive patients with heart failure. Rather, it produced a significant increase in systolic blood pressure and pulse pressure, perhaps caused by improved stroke volume due to reduced vascular resistance. So now that we can drop in the clinical evidence from the BEAT-HF study to give us the final answer to our questions, we know that Barostim does decrease sympathetic and increase parasympathetic outflow, and most importantly, it does improve heart failure symptoms. And we can take the data from the two randomized control studies looking at Barostim across approximately 500 patients with reduced ejection fraction and put that in context with the meta-analysis data that was shown earlier, and we see a great opportunity to help patients. You look at the GDMT studies on the left, and while there may be a significant improvement in hospitalization reduction and mortality in these patients, they only had the modest improvement with exercise capacity. And for patients with wide QRS, you do have a CRT therapy to offer to reduce their heart failure symptoms. However, now that there's Barostim for your patients that don't meet the class 1 indication for CRT, these show that Barostim in combination with GDMT could be a very important therapy for us to offer our patients. Just make sure here, okay. So again, we're looking at the clinical course of heart failure, which I described earlier. And again, there's, it is a declining trajectory. And so we're looking at a huge window of opportunity to treat patients with this device. And specifically, when we look at the indications for Barostim, it's actually very few indications. So we're looking at patients that are having NYHA functional class 2 or 3 symptoms. They're on guideline-directed therapy, maximally tolerated for at least 1 month. They have an ejection fraction under 35% and an NT-proBNP under 1600, and they're not indicated for CRT. So patients that we can consider for Barostim, ICD patient who remains limited in activity despite optimal GDMT. When we mentioned CRT non-responders, for reference, CRT non-responders are eligible for Barostim if they're not receiving adequate symptom relief with the CRT alone based on physician judgment. Barostim is an option as long as the patient meets the other indications for Barostim. Patients with an existing CRT device, they were not included in the clinicals, or they have been included in clinical studies. However, the numbers were too small to make any significant subgroup analysis at this time, but it is a population that we can expect them to study further. Patients who have challenges up titrating medications due to hypotension, patients who are hospitalized for heart failure due to recurrent and having recurrent heart failure related hospitalizations, and of course, very importantly, patients who are having difficulty performing meaningful daily activities due to heart failure symptoms. So we can look back at the patient I introduced at the beginning of the talk. And this was a patient that we typically see in clinic. She was on maximally tolerated GDMT. She was still symptomatic and not considered a candidate for CRT. She was referred for Barostim in July. And when we had our program up and running in late 2022, She then met with our vascular surgery department after having a carotid duplex completed, which showed no significant carotid disease, and bilateral ankle brachial indices were mildly reduced. And after the risks and benefits of the procedure were explained, she was implanted the following day on September 30th. Her KCCQ showed a 26-point improvement over 6-month time, with a maximal 6-minute walk test improvement of 143 meters by the time of her final titration. So in summary, despite contemporary GDMT, significant needs do remain with regards to the management of our heart failure with reduced ejection fraction patients. Exercise capacity and quality of life remain poor despite guideline-directed therapy for a large number of patients. Morbidity and heart failure mortality remain high despite GDMT, and patient tolerance and compliance with GDMT is poor. CRT, we know, is known to improve symptoms and quality of life, but it is only indicated for 30% of the class 2 and class 3 heart failure with reduced ejection fraction patients. And we now know that electrical stimulation of carotid baroreceptors increases signaling to the brain, which can help to rebalance the autonomic nervous system and improve heart failure symptoms. Barostim was an FDA approved based on the 6-month results for the BEAT-HF study, which did show significant improvements in symptomatic outcomes and decreases in NT-proBNP. So we can look at this as an opportunity.